Good evening, everyone. Thank you so much for being here. I'm opening a hearing for the Joint Committee on Public Health. This is an informational hearing on Lyme disease. I will be joined this evening by Senator Jen Flanagan of Leominster, who also serves this town and this district, and also by Mary Keefe of Worcester, both of whom seem to be entailed in some traffic. Today we'll hear testimony from public health and medical professionals and our local legislator. They will provide information about Lyme disease prevention, diagnosis, treatment, and advancing research. Public hearings are typically held at the State House in Boston. However, realizing how intensely Lyme disease affects individuals in our 495 Metro West area, the committee found it pertinent to hold a hearing locally where residents very familiar with the effects of Lyme disease could truly benefit from some of the information. We also plan on doing an informational hearing, likely at the State House, possibly out here, where we hear from folks that have also been affected by it and advocates that would also like to testify about the disease. Before we proceed, I'd like to remind members of the committee and the audience turn off cell phones. Testimony is by invitation only. For those witnesses testifying, please keep it to about 10 minutes, but we know what you need to say is important, so we understand. At the end of the hearing, the staff and I will be available for approximately 1/2 hour in the event that any individuals have questions about the testimony. I would like to open testimony by introducing Representative David Linsky of Natick. He has really been so very important in discussing Lyme disease and putting together a very important piece of legislation that is well on its way now to being enacted. He's filed House 901 during this legislative session, and we'll talk about his legislation, which focuses on Lyme disease insurance coverage. So welcome, David Linsky. We're asking folks to testify at the podium for purposes of rebroadcasting this.
Thank you very much, Representative Hogan and Chairwoman Hogan. And I commend you for the work that you've done on behalf of all of the people who've suffered with this illness, and how well you represent the people of Maynard and Hudson and Stowe and Bolton and all of the people in this area. I had the privilege of serving on the first Lyme disease commission in the Commonwealth of Massachusetts, and it was a commission that was set up as an outside section in a budget, and we had the opportunity to meet with literally hundreds of people and learn a great deal about Lyme disease. One of the recommendations that came out of that commission was to do something about insurance coverage for long-term sufferers of Lyme disease. And so I'm here to speak about the status of that bill and the importance of that bill. And I appreciate the opportunity to spend a few minutes with you tonight. And Lyme disease is a national epidemic, and the Centers for Disease Control and Prevention indicate that the number of Americans diagnosed with Lyme disease each year is around 300,000, making it the most commonly reported tick-borne illness in the United States. While some patients who contract Lyme disease in Massachusetts are treated effectively, numerous other patients encounter issues receiving adequate treatment and often experience difficulty accessing their prescribed treatment due to denials from insurance companies and the high costs associated with that treatment. While we allow doctors to prescribe long-term antibiotic treatment for Lyme disease, sometimes we expect those patients to pay for it out of pocket. In response to that, I filed legislation. Massachusetts prides itself on being a hub for medical research and treatment, and yet hundreds of our residents leave the Commonwealth each year to receive treatment from out-of-state Lyme specialists. Many more have experienced extreme financial hardship. Some patients have reported that a lack of insurance coverage for Lyme disease treatment caused them to accrue medical debt of over $50,000. I would encourage you, Madam Chair, to listen to the stories of individual patients and their families who've had to deal with this hardship. As a state representative, I've been an advocate for the Lyme disease community and filed legislation that requires insurance companies to provide coverage for Lyme disease treatment as prescribed by a licensed physician. In addition to this legislation, language requiring this mandate was included in both the House and Senate versions of the fiscal year 2017 budget, which is currently being debated in a conference committee between the House and the Senate. While some have expressed financial concerns about this measure, an independent analysis conducted by the Center for Health Insurance Analysis found that it would cost no more than 13 cents per policy. Additionally, the legislation does not require any specific type of treatment, as that decision should be made between patients and their physicians. The legislature has heard testimony from countless Massachusetts families who have experienced financial ruin because of Lyme disease. It is my hope that the passage of this legislation will not only make treatment more accessible for the thousands who suffer, but will raise awareness about Lyme disease and encourage others to continue the conversation of properly responding to this epidemic. I'd like to thank Chairwoman Hogan and particularly Speaker Robert DeLeo, who supported the House's version and the House's attempt to put this into the fiscal 2017 state budget as an outside section. A piece of procedure so that people understand that. Because there were some differences between the language that the Senate passed and the language that the House passed, there is still no guarantee that this legislation will end up on the governor's desk. It will be up to the conference committee that's currently meeting, the 6 members of the conference committee, to come to an agreement. If they do not come to an agreement, the matter will be put aside and will not reach the governor's desk. Assuming they do reach an agreement, that conference committee report then needs to go back to each the House and the Senate and be passed as part of the fiscal 2017 budget. At that point, the budget then proceeds to the governor. The governor has the right, as to all sections of the budget, including this one, to either sign it, veto it, or send it back to the House and Senate with an amendment. So that I'm encouraging people who have an interest in this piece of legislation to express that interest to their own state representative and their own state senator and make their wishes known. And if in fact it does reach the governor's desk, and it will do it sometime before we break on July 31st, one way or another, and to contact the governor's office and urge him to sign this particular piece of legislation. Again, the importance of this legislation is as follows. It does not mandate any particular type of treatment. That issue is left squarely between a patient and a patient's physician and healthcare providers. It doesn't mandate any type of treatment. What it does mandate, however, is insurance coverage, the same that we have insurance coverage for virtually any other type of illness and prescribed treatment. And the idea is that if patients need this type of treatment, that patients should not have to go into bankruptcy or financial ruin in order to receive that treatment. Madam Chairwoman, I thank you for this opportunity. It is a pleasure, as always, to be in the town of Bolton. And I'd be happy to answer any questions that you or anyone else has. Thank you.
I had one. Do you see any major differences between the
Yeah.
Senate version and the House that
Yeah.
are going to be difficult to come to an agreement with? in
Hopefully
conference?
they won't. There are some differences, and people who know a lot more about this issue than I have pointed out that some of the specific language in the Senate version, although well-intentioned, they didn't mean to do this, unfortunately create some problems. And as such, I think it's clear from people who know a lot more about this issue than I do, that the House version is preferable. As a result of that, Senator Goby, who is not from an area not too far from here, slightly west of here, has organized an effort within the Senate to be able to have their senators communicate, sign on to a letter to the Senate members of the conference committee saying essentially that the House version is better. And I commend her for doing that, because that's a tough thing to do sometimes, basically to admit that they may have made a mistake. So for people who are interested in this issue, I would strongly urge them to contact their state senator and ask their state senator to sign on to Senator Goby's letter asking for the House version of the bill.
Thank you so much, Representative Linsky, and I know you went out of your way tonight to come here to testify and are now on your way to Foxborough.
That's right. One of my good friends, who's a constituent, Doug Flutie, is getting an important award at Gillette Stadium tonight. So, yes,
thank you for taking your time out. Thank you. Next, we'd like to bring someone up on the prevention side, and that would be Assistant Commissioner Kevin Cranston, Assistant Commissioner and Director of the Bureau of Infectious Disease and Laboratory Science at the Department of Public Health. Welcome. He became Assistant Commissioner this February and has been the Director of the Bureau of Infectious Disease for the last 7 years, and he'll be speaking to us tonight about various prevention methods.
Thank you, Madam Chairwoman and members of the committee. Thank you for this opportunity. Lyme disease and other tick-borne illnesses are some of the most commonly reported infectious diseases in Massachusetts, and as I suspect members of the audience know, can cause significant disability and long-term suffering. So we're very pleased to have an opportunity to talk about its prevention. My presentation, next slide please, has many more slides than I can fit into a 10-minute presentation. So please bear with me. I'll probably click through a few. But these are the offending organisms, the ticks most associated with tick-borne illness in Massachusetts. Next please. Even though this says actual size fits on a card about this big. So the deer tick nymph is so tiny, it's about the size of the period at the end of a sentence on a printed piece of paper. So we're talking about what can be a very tiny to almost freckle-sized organism. The dog tick can be considerably larger, and while it's named for its affinity for dogs, can also affect human health as well. Next, please. I won't walk through all the Latin on these slides. Know that we're talking primarily about Lyme disease, but we've seen the emergence of babesiosis and human granulocytic anaplasmosis, or HGA, as also very important tick-borne illnesses, and other tick-borne organisms are also emergent in Massachusetts. And I probably will defer to Dr. Nev and other presenters to talk more about the clinical side of these concerns. Next, please. I really want to draw your attention to sort of why tick-borne illnesses are a growing part of our public health problem. And first we need to do a little basic public health. It's not enough just to have the spirochetes, the actual organisms that cause these tick-borne illnesses, but they have to be present in your environment. And part of that is because they are present in reservoir species, deer, white-footed mice in particular, being animals in the environment that carry the organism, making it available. They get it from the ticks, but they also make it available to the ticks so that when they are the vectors, so that when humans come in contact in these environments, we have the perfect storm, if you will, for the transmission of a disease of public health importance. Next, please. Lyme is a relatively recently discovered disease, but probably has been in existence for tens of thousands of years, even in the local environment. But we have seen more of it locally, in part because we've seen some changes in the environment. The forested areas that were clear-cut in earlier centuries have been largely restored. So the habitat that supports this complement of organisms has been restored. Deer populations have increased. The white-footed mouse population has increased. We have other, the black-legged tick is another name for the deer tick, have likely increased in number as well. Therefore, the organisms, the bacteria or mycobacteria, the spirochete associated with Lyme and other tick-borne diseases are more common, and people are closer to where these environments are. Next slide, please. This just describes when the Europeans first settled New England, it looked like it does on the left side of this picture, but with the advent of agricultural resources throughout the region, clear cutting of those forests really eliminated large swaths of this environment. Next, please. Making it look in this bucolic agricultural environment. This is what it looked like in New England through much of the last century, even the early part of the 20th century. But through aggressive conservation efforts, it looks more like this, which is people and forested areas being very close up against one another. We like to live in forested areas. Bolton is a beautiful community, in part because of its reforestation. But we like to be close to these environments. Next, please. And this would be somewhat an idyllic backyard if you're so lucky to live in an environment like this, where your living space, the space where deer and mice are living, where the ticks are living, are all right up against each other. And it's very inviting to take a walk down that path, but know that you're entering and taking and recreating in a ticky area, as we would call it. And therefore, next, all of the vector, the reservoir organisms and human beings come together in this environment. Next, please. I'm not going to go into a great deal of detail, but it's important to know that the life cycle of the tick is dependent on these reservoir animals and is actually a 2-year cycle from egg laying from adults through the nymph phases, which overwinter and then continue their life processes both by feeding off of the reservoir animals and human beings in order to become adults, to lay eggs, to start the cycle again. Next, please. And therefore, we have there's really no part of the year that's absolutely free of ticks. Certainly when the weather is deep cold, the ticks are not active, but we consider the tick season to start as early as March, and in warm winters as early as February in many parts of Massachusetts, and extend all the way through past the killing frost. It's not like the mosquito season, that anytime it's warm enough for the ticks to be active, they will be active because they need to be. It's part of their life cycle. Next, please. And again, not going into a great deal of detail, but this is Lyme, babesiosis, and anaplasmosis. Clearly, most transmissions and most disease reports happen during the warm weather months, the summer months in particular. But we have reports for Lyme really spanning the entire year. Somewhat, this is a function of when people get diagnosed with illnesses, as a result of Lyme disease. But note particularly HDA or anaplasmosis, we see significant reports much later in the year than the other tick-borne illnesses. There's no absolute safe time. There's no simple, silver bullet response, but prevention is the key to avoiding tick-borne illnesses. Please. So this is your sort of one-stop shopping for prevention. I'll go into a little more detail. We hope tonight's presentation, testimony, and your general knowledge helps you be aware of the risk of tick-borne illness and be able to identify ticks when you see them. We strongly urge the use of EPA-approved tick repellents. They are very effective in preventing the tick from grabbing onto you in the first place or wanting to stay on you once they do. I just want to say, ticks don't fly, ticks don't jump, ticks grab. You need to brush past a plant life that a tick is on, and it grabs on. They're designed to grab onto fur, clothing, and then they find a place on your body where they can take their blood meal. So doing a tick check or having someone do a tick check on you after you've taken a walk or been gardening in a ticky area is an effective way of preventing that first insertion of the mouth part. It takes some time before they will take that blood meal. So finding the ticks beforehand, and we have some materials that describe how to do a tick check. Knowing the tick when you see it, removing them, and I'll talk about removing them in a moment. And if you're symptomatic, if you get a rash, and Dr. Nev will talk about that the rash is not always present, but other symptoms that may be associated with tick-borne illness, getting prompt medical attention can be critical in preventing more serious disease. And remember, your pets may be at risk as well, particularly dogs. Ticks like to be where it's shady, damp, forested, brushy, and leafy. That's kind of all over. But being aware of those environments and thinking ticks when you're recreating in those environments is an important part of prevention. If you're lucky enough to have a yard of this size up against wooded areas, you may want to, if you're designing your garden or redesigning your backyard and garden, create barrier zones, particularly on the left side. That's gravel, about a 3-foot gravel barrier between your wooded areas and your grassy areas. Ticks don't like to walk across paved roads or gravel. They will stay in their damp, musty areas. And that also can actually create some benefit for you as well. Tick repellent should be applied before you go out on exposed skin, but also can be applied on the exterior of the clothing. Remember, the ticks like to grab onto clothing, so applying the tick repellent to the clothing itself will also prevent the tick from getting on and then finding its way to a skin area. Next. The EPA website is a great place to look up tick repellents. You can read the package when you purchase your tick repellents in a drugstore, but there are let's just say some companies that oversell their effectiveness. The EPA has done a great job of sorting through the claims from the manufacturers and also can help you make some decisions about which ones will work best for you. This is another resources from the MPIC, also has similar information where you can plug in what you need, not just for ticks, but for mosquito control as well. Next, please. We have brochures, and your local Board of Health has access to these brochures from the DPH that really walks through how to do a tick check, hairline behind the ears, behind the neck, behind the knees, at places where there's gaps in the clothing are the most likely areas where the ticks are likely to find their way towards your skin. Next, please. A tick can be removed, so do not use a burnt match. Do not put oil on it, all those old wives' tales. The best way to remove a tick, first of all, you want to get the tick off, and you don't want to expel what's inside the tick into you. The organism is inside the belly of that tick, so you want to remove it in a way that prevents that expulsion. The tick is a living thing. It doesn't want to have its head pulled off. So grabbing the tick right at the mouth part, right where it enters the skin, with a tweezer. There are also commercial products that are specially designed for removing ticks. Grabbing at the mouth part, pulling gently and consistently, the tick will let go. It wants to let go. It doesn't want to die. And once it's removed, disposing of it properly, I frankly recommend putting it into a tissue and flushing it down the toilet. Right? I also recommend washing your hands carefully, maybe even with antibiotic soap afterwards, because you might have gotten some of the bacteria on your hand in the process of removal. And that's what an engorged tick looks like. That's often when you will first notice it, particularly on a pet, in amongst all the fur. Ideally, you want to get it off before it gets to that engorged state, but at any time, removing the tick will reduce your risk of a tick-borne illness. And then, of course, consult with your physician if you have a concern, if you have a symptom. You have opportunities for antibiotic treatment that can really make a difference in your long-term outcomes. And finally, we do have resources, both the Mass Department of Public Health and University of Massachusetts have excellent online resources for more information. And I'll leave you with a gross picture. All right. Thank you very much for your time and attention.
Thank you very much, Kevin. I appreciate your
Questions,
information.
Madam Chairman?
Thank you.
Happy to respond to questions if you need.
Okay, we're good.
Thank you.
Thank you. The next person here that will be testifying around methods of diagnosis and treatment, Dr. Navina Zubevchik is a rehabilitation specialist at Spalding Rehab Hospital and Mass General. Dr. Nev is a co-director of the Dean Center for Tick-Borne Illness at Spalding and led of the world's first Lyme Innovation Hackathon starting tomorrow at Microsoft Nerd Center in Cambridge. She completed her residency training in physical medicine and rehabilitation at Harvard Medical. Over her time as a resident physician, Dr. Nev coordinated yearly conferences at Mass General Hospital on the topic of tick-borne illness, as well as patient support groups and physician education courses. Thank you for being here, Dr. Nev.
Thank you so much for having me. It's a pleasure. So my talk, I've tried to shorten. It's usually a longer talk, so I'm happy to take questions after, but we can go next. So this is, I'm a rehab doc, And I see people when they've been sick for a long period of time. And so usually, this is what my patients tell me is the issue that they face. And it's, the bad news is you have Lyme disease. The good news is I don't believe in that disease, so you're fine. And so, unfortunately, it seems to be, this course in the medical community, and one of the reasons why that is that we lack good diagnostic tests. Doctors rely on evidence, and if you can't produce evidence and the testing isn't adequate, then the doctors lack the information to make an appropriate diagnosis, and then the patient is unfortunately stuck in the middle, trying to find answers. Doc can't help them, and so they end up suffering a lot. So next slide, please. Ticks are very small. They're a perfect vector because inside of their jaw they contain this it's like medication. It's an anesthetic inside of their jaw. So they anesthetize you prior to as they're giving you the bite, so you don't really even feel the bite. So it's pretty difficult. A lot of people will never remember being bitten by a tick because they just didn't notice it because their skin around that area was numb. Next slide, please. So what is Lyme? Really, it's become quite confusing because, in the 70s when it was discovered, it was one strain of Lyme. It seemed like a simple thing, one strain meaning one bacterium that genetically was probably, thought to be same across the country. But then later on, more research was coming out showing, well, wait a minute, it's not just one. This specific bug has many different genotypes. So when we're testing for an antibody response to this specific bug, it seems to perhaps be different when you're bitten by a tick that contains a different genospecies of this cluster of bugs. So in recent years, there's many more strains that we've discovered in the country, and we keep discovering them frequently in different parts of the country. And some strains we actually don't even have a name for. There was a recent study outside of California, with a few strains that we don't even have a name for yet, and they wouldn't test positive on the current CDC test that we have. So we're trying, everybody's trying to fix that diagnostic problem, but it doesn't happen quickly, it takes time, and unfortunately, patients on one side suffer because they're not getting the proper diagnosis. On the other hand, doctors are also suffering because professionally it's very frustrating not to be able to help your patient, but when you lack the tool, it's difficult to make appropriate diagnosis because a patient could be sick for many different reasons, for many different infections, and certainly we think now that the biggest obstacle is diagnostic tests that can really catch this disease at all of its stages, because it has the primary stage when you likely have a lot of these bugs throughout the system when you first get bitten, but then later on, perhaps not as many, and maybe they're not in the blood even as much, but they're in the tissues. And when a bug goes and seeds itself in a tissue and doesn't really circulate much in the blood, it's even more difficult to find and discover what's causing the culprit, unless you actually biopsy a piece of the tissue and look for that specific bug. So it's a big problem, and that's where we're trying to, both with prevention, diagnostics, and therapeutics, is this field really needs discovery and help and more research and more labs and people who are willing to take on and champion some of these problems to help really the world rid itself of this terrible culprit. Next, so we already went over this. There's too many people every year. The CDC sometimes, talking to the CDC folks, they're concerned that even this is an underestimation of the real problem. Next one. Also, next slide, please. The other issue is that we're not tracking co-infections really. So there's many bugs that the tick can give you. Such a tiny little vector can actually inject many. There's a study out of Oregon showing 292 organisms inside of a tick's belly. Then another study just came out showing something like 91 organisms inside of the tick. So when a tick injects, it's not just Lyme. So sometimes people are sick from co-infections, and even if the Lyme is treated, but there's babesiosis, anaplasma, ehrlichia, Rocky-Mounted spotted fever, bunch of different viruses. So it's really difficult to know, what is being the main culprit in somebody's health, or is there multiple culprits? Or is it the immune system that's been upregulated because it's not trying to fight all these infections that are difficult to conquer, that now the immune system is attacking itself and causing a problem as an additional issue in somebody's health. So it's a big problem. So we went over that, discussing the thick saliva can inhibit, a lot, the immunity, the sensation, you don't feel the bite, and so forth. Next, please. Another amazing thing about this bug is that it really is very fast. So this is a picture of a mouse blood vessel, and the green colored bug is what you're seeing piercing through the blood vessel, and it pierces like it's nothing. So it's this corkscrew-shaped organism, this bacterium, that just burrows through and can go from any tissue really anywhere. It's pretty a remarkable organism, and that's why it's so hard for our immune system to catch it, because it just is in and out of blood, in and out of tissues. It really has kind of free reign of the body once it's in. And another thing that's impressive about this organism is that it can actually travel against the flow of the blood. It's so strong with these proteins that are sort of like flagellar powerhouses for it, that as the blood is flowing one direction, the organism can actually travel the opposite direction against the blood flow and still pierce through and leave. So, one of the issues that we have in medicine is that, when we go to med school, it takes a while for us to catch up a little bit with the new findings and the new publications. So we all really study Lyme as this disease that has a beautiful, marker, which is this rash. Well, it's a bullseye. It's supposed to look like a bullseye ash, like this, target rash. But the problem is what we're discovering now, not all of those genospecies of the strain of the Borrelia burgdorferi actually gives a rash. Some, don't ever give a rash. And even Borrelia burgdorferi, which is supposed to always give the rash, doesn't always give the rash. And when it does give the rash, it doesn't unfortunately always look like this pretty, sign that says, hey, I've got Lyme. It sometimes looks like maybe a spider bite or a bruise that doesn't hurt, so it could really look very differently. Next slide, please. For instance, this is a PCR positive Lyme rash, but it looks more like a spider bite, so somebody would think, oh, don't worry about it if you were seen. So that's another issue. A big thing that we want to also talk about is, different kinds of symptoms. So adults, we always talk about this flu-like illness that happens in the summer, so it alerts the docs like, flu season isn't really happening. You've got this flu-like illness. Maybe it's Lyme. So it's a good indicator. And plus adults complain a lot, do you see any kids in this audience, right? No. Why? Well, because we don't give them a chance to really have meetings and, have representatives of their own. So the kids have a much harder time explaining their symptoms, complaining. They don't even know how to complain. I have a work colleague with a 3-year-old son who came to him and said, Daddy, I need a wheelchair. And his dad, who's, a physical therapist, was like, what? Like, do you see me with a wheelchair at work? He couldn't make the connection of why his son was suddenly saying this, and he kept saying this over and over again. And then a few days later, he broke out in many bullseye rashes, and his dad was like, oh, thank God, now I know what's going on. So the child got treated, improved, and got his energy back and stopped complaining that he needed a wheelchair. So the one thing that's important to understand is that this disease really can present like many different things, and that is another complicating factor when you see a physician, because the doctor tries to fit the illness into a certain thing that we all learn in school, like this looks like that, strep throat looks like this, headache, these are the differential ways you look at a headache. This is, so Lyme can present like so many things. It's overwhelming and very confusing, because you're looking at a picture that, could in one patient look one way and another a whole different way, and in a child, a completely different way. So it's very challenging for the docs, unless they see this over and over again, to start recognizing these patterns and start suspecting that this could be Lyme. So, no, please go back to the slide. So in children, for instance, headache is a very common factor, behavioral mood disturbances, facial palsy, sleep disturbance. And unfortunately, what I have with my patients, young adults and older adults also, is they present with encephalopathy, so memory loss. And this memory loss amazingly kind of clears up when they're put on antibiotics. Well, that has been shown in literature, is that when you treat people with intravenous antibiotics for a while, when they present with this sort of sudden memory loss, cognition, people are getting lost, they can't function normally, then they get treated, and then they're miraculously better, dementia goes away. If it's Lyme. So it's very important that we recognize these things, but again, physicians have a lot on their plate, many different diseases, so education and learning about how this illness can present in different patients and all the ways, and how can you help your patient is very crucial. And big piece, again, is prevention and diagnostics, because if you can diagnose somebody, it's so much easier to treat. Next, please. So there's this whole issue of persistence of infection, and that's probably the question I get the most when I see a patient. It's, do I still have an infection? And it's very hard to tell, because again, we don't have that test that will say, yes, you've got the bug, we saw it, we found it in your body. We don't know. So we rely on these tests that don't necessarily look for the bug, but they look for an immune response to the bug. So what we do is we look for clinical response. So we give the patient a treatment, which is usually antibiotics, and then we see, are they better? If they're better, super. If they're not better, then we keep looking. Is it a co-infection? Are we missing Bartonella or Babesia or Anaplasma, or what is going on, trying to figure out and help that patient. Sometimes patients have had cancer, right? So you don't want to miss an important diagnosis. So it's a very comprehensive workup that people need when they're very, very sick. So persistence of infection is something that came out in recent years in studies of mice, dogs, out of UC Davis, mainly the mice. Then Tulane University is a primate research lab that studied primates. And then Tufts University is now studying humans who have had what's called persistent, PTLDS, so persistent post-treatment Lyme disease syndrome. I don't really use that term. I call it, chronic illness related to tick-borne illness, because I don't know what's causing it. And I don't think it's not always post. It might be still happening as an active infection. So at Tufts, for instance, they just recently announced some research at a recent conference that people who had been taking antibiotics for years, they would put a virgin tick on them and let the tick feed, so a tick that does not contain the bacterium. And they have found patients who, once they remove the tick, they'll actually find spirochetes inside of that virgin tick, showing that people who've been on these antibiotics for years are still somehow able to retain a live organism in their bloodstream, and which is showing that these antibiotics are likely not killing all of these bugs, right? So they remain persistent in the system. So what is needed is really not just good diagnostics, because you can't be going around putting on all your patients these virgin ticks. Like, you actually need a better test than that, right? But you also probably, what we need is better antibiotic regimens that will eradicate these infections, so that patients can take them and then they're done, right? And people at Johns Hopkins and Northeastern are currently working in those labs trying to find that, what is the actual cure. Okay, next. And so repeated antibiotics, there's always that question. We've seen over 300 patients in our clinic now, and we'll be publishing some data, but patients do get better. It's with repeat antibiotics, and if you think that a subset of these patients has a chronic infection, like what this basic science research is showing, then it makes sense why. And so there's been 3 studies, and if you look at fatigue after repeated treatments, it is sustained over time. So people's fatigues will improve. Next. So there are other tests right now. There people are trying to help their patients. They use this test called Lyme C6 peptide that's supposed to catch more than one strain of the bug. But also doing co-infection testing is really important, and looking for Lyme many different ways. If you can in the lab as a physician is useful, because sometimes you will catch a strain like Borrelia miyamotoi, which we have a lot in our community, but unless you're specifically looking for it with a lab test, there's only one lab that does it here in Massachusetts, then you will miss that bug, and the patient will look like they're not sick from Lyme. Next, please. So this is another study that was done at BU, and it's a radiological study showing that 183 patients with this post-treatment Lyme disease syndrome underwent long-term antibiotic treatment, and the scans of their brains in 70% patients improved, which some resolved after taking antibiotics. So it's an important study to also look at. Next. So ultimately, as a rehab doc, I like to have my patients avoid getting sick in the first place, and that's why I'm mostly excited about prevention and early treatment, because patients then have the highest chance of getting curative treatment that will, hopefully last, and they'll be better, even though current research from Johns Hopkins and John Alcott's lab shows that 38% of people who are diagnosed at erythema migrans, at that rash that you saw. So when first tick bite happens, people get a rash, they get immediately diagnosed and put on 3 weeks of doxycycline, 38% of them will still remain with chronic illness. All right. So that is a pretty high percentage rate. But still, at that chances when people have the highest chance of actually getting better and not getting chronic symptoms. So like those 60 couple of percent of people that will actually not have a relapse. So I think it's very important, prevention. What Kevin said, I think it's really important. I think what Dr. Klempner is going to talk about is going to be the future of prevention. Prevention is one thing you have control over, and you have to practice it. Otherwise, in this field that's still developing and growing, there are no guarantees. So I'm happy to take questions later. Thank you.
Yes, and can I just ask a question right now?
Yes.
When you talk about 38% of patients remaining with a chronic condition,
Yes.
is that the full-blown response, or does it have a spectrum where it can be someone just tells you, I know I still have it, to the full-blown response where you're not really able to touch it with the antibiotics or drugs that you might be using?
So this study was published in 2013, and it was published by Dr. John Walsh at Johns Hopkins University, and he's an infectious disease doc and rheumatologist. I think he's boarded in both. But basically, they took patients who were caught at the rash. They treated them with the recommended antibiotics of 21 days of doxycycline, and then they followed them for a year to see what their symptoms are. So these people were healthy individuals who didn't have any issues before this bite. And what they found was that about 15 to 20% of them, I don't exactly remember the exact statistic, but they fell into that PTLDS criteria, which is post-treatment Lyme disease syndrome. So it's quite a bit of disability. And another 18% or so fell into another group that also had disability, but not enough to put them in that PTLDS cluster. So, but 38% actually had chronic symptoms that remained after the antibiotic. And we do not know what the reason is. Was it persistence, autoimmunity, inflammation? There's no information in that specific study, but it's a very important study showing that, the treatment that we give perhaps is not enough or sufficient, or are we missing a co-infection in these people that should be treated differently, like the babesiosis that requires a different kind of antibiotic regimen, and we're showing that huge amount of ticks, Kevin probably knows the number better, are co-infected with Babesia. So are people not getting better because we're missing a co-infection, perhaps?
My other question was, in terms of that, where do you feel like we are in terms of understanding the infection and then treating the infection? Do you feel like we understand it even less than we have evolved in our treatment of the disease? I mean, do you feel like you're coming up against questions constantly in terms of diagnosis and new
Well, so new
infections and
pathogens, we're
co-infections?
finding new pathogens all the time, right? Like viruses and protozoans and more bacteria that these ticks contain, which is very alarming and concerning, because before we thought the picture was a lot simpler. But now, when I see a patient, I have no idea. Some of my patients have Q fever. We thought, well, Q fever is rare, but now it's like, why does somebody have a Q fever when it's supposed to be, very rare disease, but the ticks can carry it, and we're not able to yet monitor it. There's only so much federal funding to do surveillance on all of these bugs. So, that's another issue is, we don't really know what our patients are sick from. So it's a growing, we'll learn as we go.
And I guess what I'm asking too is, where can government be helpful? Where can we think about it in terms of both public health and investing in research in terms of where you are understanding the infections?
So I think more funding toward understanding of what ticks carry is very important. We don't even know what's in our backyard, like what the tick in our backyard carries as a disease. So that information is useful for the patients, but for the physicians as well, because then they have an idea. We've had a patient from Dover who had Rocky-Mountain spotted fever. Well, that patient's lucky that the physician thought about that, because Rocky-Mountain spotted fever really is not something we think about in Massachusetts, but it's here in our ticks. So, that is a big issue, is really learning what's inside of our ticks. So that kind of study, more federal dollars to go to schools and, teaching people about prevention. You got Dan the Tick Man here with all kinds of cool ideas, but it's important. This is why the hackathon is happening tomorrow. So it's a 3-day event where we have government agencies, entrepreneurs, the academia, students, clinicians, everybody coming together to try to innovate and come up with ideas on how to better do prevention, diagnostics, therapeutics, and offer a platform for companies that are percolating and trying to launch a product to have opportunities to meet with investors and people outside the government sector who perhaps have dollars available now to invest into an important cause, given that it takes time to get federal money and state money devoted. But I think it's an epidemic. We all know it. It's everywhere. Everybody knows somebody who's affected, and I think these sorts of initiatives are crucial to help us, tackle this epidemic.
Thank you. Thank you, Dr. Nev.
Thank you very much.
I want to now introduce UMass research on immunization. Dr. Mark Klempner is the Executive Vice Chancellor for MassBiotics and Professor of Medicine at UMass Medical. Dr. Klempner is internationally known for basic infectious disease research and the development of therapeutics and vaccines to combat infections. He'll be sharing with us today some of the exciting research he is doing on new ways to prevent Lyme disease.
Good.
Thank you for being here.
And thank you for the opportunity. I'd like to answer your last question a little bit first as I talk about prevention, because many of us in this room are aware of many infectious diseases, and by far the best return on investment in infectious diseases is on prevention. There's no question that if you can prevent the infection, you're far along, and you don't have to deal with all of the other things going forward. But it's a plug for that. And I'm here really just to talk about the prevention aspects for Lyme disease. And so if you could put that next slide up. I had to at least begin with a small advertisement for your Department of Public Health, because MassBiotics, which is where I work, has its origins in the Department of Public Health, and it's where most all of this work is being done. Our labs are in Mattapan. They were formerly exactly the same place, so over in Jamaica Plain. And now we also have a place where we make gene therapy products down in Fall River, and that's the lab on the bottom. Next slide. Just to tell you that MassBiotics, this organization, began in 1894 with the sole focus of preventing infectious diseases and treating them for the citizens of Massachusetts. And we still have that very much as a focus. And during our 122-year history, we've made a lot of different medicines that have been focused on exactly this. Next slide, please. We've had a tremendous evolution of our technology in the ability to make these medicines. We started out using horse serum. That was the first medicine that was used for preventing and treating many infectious diseases. And there's a horse up there by the name of Captain that was responsible for 86,000 doses of anti-diphtheria antibody and prevented more infections and treated more infections in children that were dying of diphtheria in the early part of the last century. We moved along, and what I'm going to talk about is the creation of a new type of treatment for this called a monoclonal antibody, which is now made in these steel tanks over here. So it's a very, very pure product that we are able to make. Next slide, please. This is just some of the medicines that we've distributed to the citizens of the Commonwealth using these technologies, and you can see that some of them have been directed against some what are less common infectious diseases now, but we still make some of that, not the horse serum medicines, for distribution philanthropically throughout the world. But you will see here that we've been working on a monoclonal antibody for Lyme disease, and that's really what I'm here to talk to you about. Next slide, please. Okay, so we actually know quite a bit about how to prevent Lyme disease in terms of the biologics way to do it. And what I mean by that is you've heard quite a bit that preventing getting bitten by a tick is the best way by far to prevent getting Lyme disease, because then you've got no chance of getting it. But should you get bitten, we know that if you have an antibody in your circulating in your bloodstream, when that tick bites you, that it will prevent Lyme disease. And that's what these studies speak to here. That when you give people the vaccine that was available in the late 90s and early 2000s, they develop a whole bunch of antibodies, as I'll tell you in a minute, and at least one of them can do this. And the vaccine was fairly effective when given with 3 doses, about 80% effective, 78% effective for preventing Lyme disease. Next slide, please. So this was the idea of how the vaccine worked. It was that you gave an outer surface, a piece of what the tick is wearing on its outside, so-called outer surface protein A. You gave that to a person as a vaccine. They then would respond to that protein by making hundreds of antibodies, and we've mapped actually how many antibodies are made. And a very tiny subset of them were able to kill the bacteria, and the vast majority had no effect or had deleterious effects. But the idea was that the tick would attach, it would take a drink of your blood, it would say, hey, that blood has poison in it, it would kill the bacteria in the midgut or the belly of the tick, and that would prevent transmission. And that's how it works. Next slide. The problem is there were a lot of problems with this vaccine. That it made many antibodies, just like all of vaccines induce, and it required you to get 3 shots over 6 months. So you had to start taking your prevention in basically November or December, maybe even earlier, to get your last preventive shot in May. It was only effective that we knew about in adults. We didn't know about children at the time. And the immunity only lasted for a year or 2. And so this were a whole set of problems with this, and for those reasons, as well as many others, it got taken off the market. But what we've learned from that is that inside the animal that receives that outer surface protein vaccine, there is going to be an antibody that will kill the tick, kill the bacteria in the midgut. And that's what we searched for. And next slide is exactly what our idea was, to take this monoclonal antibody, just one single antibody that we know is able to kill the bacteria, give that to a person, and then they should be protected. And this was that idea where you get the anti-OSP-A human monoclonal antibody. That's what all that stuff stands for up there. And it attaches to the person. The tick does. It takes a drink. It has that antibody in the blood and thereby prevents the transmission to you. Very different than a vaccine. We've used the information from the vaccine to try and identify the specific antibody that will work. Next slide. Okay, so what we did is we took that OSP-A protein, we put it in some mice that have a human immune system in them. We call them humanized mice because they make the exact same immune response that a person does. And what we did is we then took the cells from those mice and we said, okay, what antibodies do they make? Next slide. And it turns out they made 593 different antibodies, and 93 of them were distinct. When we sequenced each one, we saw the letter code for each one. And then what we did is we put a little bit of each one of those 93 different antibodies in a test tube containing Borrelia burgdorferi, the bacteria of highest interest. And if it killed the bacteria would release ATP, which is the big energy source, that would then interact with some stuff in the test tube that would glow and show light. And so we just basically looked at these 93 antibodies and said, okay, which ones cause the bacteria to the test tube to glow? And we found that some of them were able to kill the bacteria. Next slide. And this just shows what they were able to do. At the top is fully alive, % of the live cells, and if you take a completely irrelevant antibody, it doesn't kill anything, and that's what those orange bars are across. But if you use some of these antibodies that just have numbers up there, they do kill the bacteria, and the number of living cells falls dramatically. So that's done in a test tube. Next slide. We look very carefully exactly where this one antibody interacts with that outer surface protein A, and it's on none of the places that people had previously expressed concern that it might be cross-reactive and cause arthritis instead of preventing infection, and it doesn't do that. It's in a different, distinct location. Next slide, please. And so the next thing was to say, okay, let's do a series of in vivo experiments where we actually give a very susceptible animal, the mouse that is actually the reservoir for Lyme disease, and try and see if we can prevent a tick from transmitting it to a mouse. And so what we did is we give them the monoclonal antibody on day 1. We then put 6 infected ticks on that mouse, and we say, we then leave them on for a week, and then we let the animal go along for another couple of weeks, and then we test that animal to see if it became infected. Next slide. And here's the result. When you take a control antibody, meaning one that's irrelevant, it's not directed against anything that interacts with the bacteria causing Lyme disease, it has 0 protective effect. 100% of the animals become infected. In contrast, and I'll just focus your attention on 2 of these, 31944 and 221.7, were 100% effective when given at that dose, 10 milligrams per kilogram, which is a dose that is actually achievable in people. Next slide. We then did some dose reductions, and both 31944 and 221.7 were able to be 100% effective at much lower doses. And right now, we are actually in the middle of the experiments to try and find the minimum effective concentration that you need to have circulating in the blood in order to prevent Lyme disease in this animal model. The real challenge is that antibodies typically, when they're given to you from the outside, exogenously, and you don't make your own, last for about a month. They have a half-life of about 15 days, at least these type, And so if you can go through 2 half-lives, which is pretty easy, you have 30 days. As you've seen today, we have a 7-month problem here. Well, we have a 12-month problem, but at 7 months would occupy 95% of all the infections. And so what we've been most recently doing is trying to engineer this antibody so that you could go to your CVS, get your shot in the you're immediately immune as soon as you get the shot. So you would go there, say, in end of March, early April, and it would last for 7 or 8 months, that antibody shot. And this, go back one, and this is just showing that with some engineering of the antibody to make it last longer for the whole tick season, we've been able to go from 16 days of a half-life to 51 days, and we now have one that's 108 days, and that actually is long enough that would give us 225 days or so of protection, and that would cover the vast majority of the period at risk. So that's kind of where we are. I do want to close by saying that we're quite confident of the safety of this approach for 2 reasons. Number one is we give more monoclonal antibodies to people for other things, for gamma globulin shots for many, many years, and they have been incredibly safe. But really the key to safety is the specificity here. We know when we give our most vulnerable infants in the world, children who are susceptible to something called respiratory syncytial virus, that if they get an antibody shot, one specific monoclonal antibody shot, when they are in their early weeks of life, that they are protected from getting that infection. So a monoclonal antibody to prevent a very deadly respiratory infection is the standard of care right now. And that has been incredibly safe for over 12 years now. There hasn't been a single really serious adverse event to the receipt of this drug called Synagis. And we believe that this will likely be just as safe as that. So next slide. That's where we are. We have patents on these medicines through the medical school. These are not patents I own. This is the medical school. Actually, this is the state of Massachusetts owns those patents so that they stand to be remunerated from it. We are, as I told you, doing the last animal testing of this extended half-life monoclonal antibody. We need to then manufacture the toxicology lots to make sure that it is safe. And then we have to plan the clinical development, meaning giving it to people. The path is very clear. There's a phase 1 and a phase 2 study that needs to be done early on, and then an IND filing, and then that phase 1 study. So I hope that I've at least given some hope here that there is a future for prevention that is not a vaccine, because I think that there is quite a bit of antipathy towards vaccines in general. And I want to be clear that this is an approach that is really based on giving the specific monoclonal antibody that will prevent Lyme disease. And hopefully it will come to pass in the next several years. And I thank you for your attention, and I'd be happy to answer any questions.
Yes, Doctor. What does the timeline look like for this in terms of being in the phase 1 study?
Yeah.
What is a timeline? Not that you can,
Right.
really
So all the funding
truly...
for this has come from the National Institutes of Health in multiple forms, right? So this has been federally funded research. So the timeline is heavily dependent on an investment on being able to do exactly that. We need something on the order of $4 to $6 million in order to be able to accomplish this through phase 1. A fair amount of that is just manufacturing a safe lot of the medicine. And so that could be done fairly promptly. I believe that you could get through the phase 1 study within 24 months. Manufacturing, toxicology, and phase 1 study showing safety and pharmacokinetics, and that the next year could be move into efficacy trial.
So you would even see 2 to 3 years?
I
maybe
see 2 to
5
3 years
before?
for collecting the data that would lead to a clear picture of efficacy and safety in humans, and then it would move on to what are called registration trial, and that would probably take another year or 2. to do that. It depends on whether you had to do it in 2 seasons or not, because you're stuck here with seasonality. And so a horizon of 5 years for the whole package is at least considerable.
And when we were talking earlier about co-infections,
Yeah.
this is sort of the one shot hits all, and
No.
so
No, in fact, its greatest selling point is its specificity. So that means that it is only going to prevent Lyme disease. Its greatest deficit is that it's not a catch-all like no vaccine is, or no approach like this. You know, we're talking about, as you heard previously from Dr. Nev, that there are multiple different, not different Borrelia burgdorferi. This will actually cover all the different Borrelia burgdorferi strains that we've ever tested. But it won't cover Anaplasma or Lichia, and one of the newer ones we don't know, Miyamotoi, it doesn't seem to have this same outer surface protein.
thank you. Thank you, Doctor. Thank you
Thank
so much
you.
for your testimony. And to wrap up the evening with the local impact, we have Don Lowe, our intrepid town administrator from Bolton. He's been here for over 7 years, and he was previously Director of Community Economic Development for Clinton, and he'll be speaking very directly about the impact of Lyme disease here in Bolton. Thank you, Don, for being here tonight.
Thank you, Madam Chairwoman, for inviting me. I do want to give just a local slant on how Lyme disease impacts the town and how we view it from the local level. First of all, I would just like to share that for the time period from July 1st, 2015 to June 15th, 2016, there were 34 confirmed cases of Lyme disease in Bolton. And from July 1st, I'm sorry, that was for 2016. And from July 1st, 2014 to June 30th, 2015, there were 34 confirmed cases. So between the 2 years, we had 60 confirmed cases, which is actually higher than I would have thought. But again, from the local level, it's important to keep in mind that what we receive for cases at the local level, at the Board of Health level, and what the state considers actual cases for statistics are laboratory-based, which is true for all communicable disease investigations, not just tick-borne illnesses. Local labs and clinicians are mandated to report certain diseases to the Department of the Board of Health, and many to the Department of Public Health, and many are connected with the state lab for that particular reason. It's the lab data from the Department of Public Health that begins the workflow for us at the local level. With regard specifically to Lyme disease, this means there could be many more people that are diagnosed with and being treated for Lyme than are reflected in these numbers. Lyme disease is clinically diagnosed. A healthcare provider may obtain labs to help out the clinical picture and diagnosis together, but mostly other factors account for an actual diagnosis. Those factors are symptoms, history of tick bite, geography, if you're in a high-risk area, the time of season where we're at our peak, and other risk factors such as frequent outdoor activity, such as hiking. And of course, you know, Bolton being a very outdoor-oriented community, we have many attractive trails here. You know, we are a very active community, so we would be exposed to that type of thing. And just to, from a personal level, speak to what the previous 2 speakers referenced, I can't imagine a better bang for the buck, if it would be, than to focus on prevention. I personally have a friend whose son, when he was in his early teens, contracted Lyme disease, but went undiagnosed for 7 years before they finally discovered what his problem was. And the symptom that he had was in the 38% of children who exhibited extreme listlessness. Now, trying to get a teenager out of bed in the morning who's healthy is difficult enough. Trying to get one out of bed who has this disease was unbelievable. And it had an emotional impact on him as well as a physical impact. The child never did graduate high school. It had certainly an emotional and financial impact on the family. as they went through to doctor after doctor after doctor, traveling the country, trying to find someone who could diagnose this properly or accurately. So it's actually a life-altering experience at that age. The child will probably never be the same, not a child anymore. So any funds that could be put towards prevention and early diagnosis, I think, would be extremely well spent.
Thank you.
Thank you, Madam Chair.
Thank you, Don. So it closes the hearing. I hope it was informative and tools at your disposal for both preventing and treating Lyme disease. Please remember that in the fall, we will probably host another hearing either out here or at the State House to listen to both those folks affected by Lyme disease and also their advocates, of which I've already heard from over email. If you have any questions, I will be here for the next half hour. Perhaps folks could stay if they're able to, might have individual questions. And so I will call at this point this hearing closed. And also, for a point of personal privilege, I'd just like to let folks know who are Bolton and local residents that this Sunday, June 19th at 8 p.m., the First Parish Church of Bolton will be holding a candlelight vigil for the victims of the shootings in Orlando. That will begin at 8 p.m. this Sunday evening, and it will be between the First Parish and the Bolton Town Hall. Thank you, everyone, for being here, and again, we'll be here for a half hour. There's water in the back, and thank you all for coming.